Hey everyone, we've got another specimen today. This is number 722 in our collection. The heart would have sat roughly in the chest like this, anterior surface towards the screen, posterior surface towards the turntable, head or superior up here, legs or inferior over here, left over here, and right over here. Let's start off as we usually do, which is by trying to identify the right atrial appendage, at least externally what appears to be that. And here we find a triangular, broad-based or pyramidal right atrial appendage. So we'll go ahead and open up the heart here. And when we do that, we do find pectinate muscles that spill outside the confines of the appendage, consistent with the morphologic right atrium. Then when we look at the atrium itself, we see that the atrial septum is intact. The oval fossa is intact. Here we find the mouth of the coronary sinus. Here is the Thebesian valve, which guards the mouth of the coronary sinus. And then here's the right-sided atrioventricular junction. And we know that the right-sided atrioventricular junction, the coronary sinus, and the tendon of Todaro, which is right here, form the triangle of Koch, and it is at the apex of this triangle where we expect the atrioventricular or AV node to be. So we'd expect the AV node in this heart to be here. In this specimen, we also have the superior caval vein still intact. So here it is, draining into the superior aspect of the right atrium. So here is the mouth of the superior caval vein draining into the right atrium. When we look at this right-sided atrioventricular valve, we see that there are 3 leaflets, 1, 2, 3. There are direct connections to the ventricular septum, consistent with the morphologic tricuspid valve. This ventricle here has coarse trabeculations, and there is a septomarginal trabeculation, aka a moderator band, with its cranial and caudal limbs, all consistent with the morphologic right ventricle. Now, when we get to the first arterial valve, or semilunar valve, we find that there's a valve with 3 leaflets, 1, 2, 3, and 3 sinuses. No coronary arteries arising from any of these, and a completely muscularly supported arterial valve, all consistent with a morphologic pulmonary valve. And as we've pointed out before, important to note that the arterial valves, the annulus is not actually round or oval in shape. It's actually this crown-shaped structure here. That's not to say that the basal ring or the round or oval annulus that we create clinically isn't helpful. It's just to say that the true annulus is actually not round in the arterial valve, because these fibrous valvar leaflets have these triangles of myocardium interposed in between them. Here's the pulmonary trunk, and then we do see that the branch pulmonary arteries arise from the pulmonary trunk. So here's the orifice of the right pulmonary artery, and here's the orifice of the left pulmonary artery here. Now let's go ahead and flip this heart over. And here's the posterior aspect of the heart. We'll open up this ventricle here, and we do see that there's a smooth-walled atrium here, consistent with a morphologic left atrium. Let's see if we can find the appendage. And here is the left atrial appendage, and here is the entrance to the appendage, and we see that there's no pectinate muscles that spill outside the confines of the appendage. And here's a pulmonary vein here, and here's another pulmonary vein draining back to the left atrium here. Looks like there's some sutures here in the area of the oval fossa, so perhaps there was an oval fossa defect that was primarily closed. Now, when we look at the mitral valve here that guards the left atrioventricular junction, we can see that it's a highly abnormal valve. First of all, it's pretty small. We do know it's a mitral valve because there do appear to be 2 leaflets, one over here and one over here, but you can see that these are very small, dysplastic, rolled leaflets. We also see that this leaflet has no direct connections to the ventricular septum, also consistent with the morphologic mitral valve. But a very small and dysplastic mitral valve. If we try to put together the valve itself, You can see this little slip by my thumb is actually what the orifice would have been. So a very small and stenotic orifice to the mitral valve. And you can see that its attachments are also abnormal. And it almost looks like a single papillary muscle. So a very abnormal mitral valve with mitral stenosis. Here's the left ventricle. You can see that the left ventricle is significantly smaller than the right ventricle. So here's the right ventricle once again. Here's the left ventricle. So a small left ventricle that is a little hypertrophied. But we know this is a left ventricle because there's a mitral valve attached to it, and there's fine crisscross trabeculations and no septomarginal trabeculation. And then when we get to the aortic valve here, we see that there are 3 leaflets, 1, 2, 3 sinuses, but you can see that the annulus is quite small, or the basal ring, I should say, is quite small when compared to the pulmonary valve. So a smaller aortic annulus, and remember once again the true annulus of the aortic valve is not round or oval in shape, it's actually triangular. What sets this apart from the pulmonary valve, however, it's that the aortic valve is not entirely supported by muscle. There is aortic to mitral fibrous continuity, and here you can see that fibrous continuity. So the aortic valve does have a smaller basal ring, although it does have 3 leaflets and 3 sinuses. So here we're really looking at a heart with small left-sided structures, an abnormal and stenotic mitral valve, a small and hypertrophied left ventricle, and then an aortic valve that's formed appropriately but has a small basal ring, or what we would call clinically the annulus. I think it's important to comment that we shouldn't call these hearts Schoen's complex. When Schoen first described his constellation or complex in 1963, it consisted of 4 distinct findings, and that was that of a supramitral valvular ring, subaortic obstruction or subaortic membrane, and coarctation, and a parachute mitral valve. Eponyms can be helpful, but we all have to understand what they mean, and if we throw it around for anything with small left-sided structures, not only can it be misunderstood, but it really doesn't convey any specific information, and so we should just describe the heart as it is. So we've got a heart here today that's got small left-sided structures characterized by a mitral valve that is small and dysplastic, also a small left ventricle, an aortic valve that has a small basal ring.